Good afternoon, everyone, and welcome to this month's Region 7 Preparedness webinar series, Accounting for the Social Detriments of Health and Ethical Considerations in Preparedness. Today's webinar is going to be presented by Dr. Abby Lowe, who leads the Health Equity Initiative for the Region 7 Disaster Health Response Ecosystem Grant. Just have a few disclosure information here. So webinar descriptions on the screen. Our objectives today are to define the social detriments of health and their relevance to preparedness and response, describe key ethical values and ethical considerations relevant to preparedness and response, and identify an equity issue in preparedness and response, as well as recommendations for action. Today's webinar is accredited for 1 continuing education hour. The faculty has nothing to disclose for today. The planning committee does have a disclosure for Dr. James Lawler. If you have any questions today during the webinar, please paste your questions into the Q&A function on your Zoom screen, and we'll answer the questions at the end of the webinar or live through the chat. Following the completion of the webinar, you'll go to this website listed here on the screen, evaluate your activity with the activity code ENTER in order to claim your CE. And with that, I'll go ahead and introduce our webinar speaker. Today's speaker is Dr. Abby Lowe, who is an assistant professor in the College of Allied Health Professions, Department of Allied Health Professions Education, Research and Practice at the University of Nebraska Medical Center and a UNMC Global Center for Health Security Scholar. Abby's interests are at the intersection of ethics, health policy, and health security, and her research focuses on ethics in public health emergencies. Her work has been published in the AMA Journal of Ethics, the Journal of Law, Medicine and Ethics, and the Journal of Public Health Policy, among others. In March 2020, Dr. Lowe convened the Global Center for Health Security Ethics Advisory Committee with national and international experts in disaster and public health emergency ethics to provide guidance on emerging issues related to the COVID-19 pandemic. She also leads our Health Equity Initiative for the Region 7 Disaster Health Response Ecosystem. And with that, Abby, I'll turn it over to you.
Thanks so much, Lauren. And I'll go ahead and share my screen here. Okay. Lauren, are you able to see my slides? Everything looking okay?
Yep, good to go. Thanks, Abby.
Yep, good to go. Okay, great. Lauren already covered these, but the one thing I'll mention, we are going to talk about the social determinants of health and their relevance to preparedness and response. And we're going to talk a little bit about ethics and ethical considerations as well. And then our equity issue that we'll be focusing on today is going to center on work. So just kind of there's a lot of ways, as I'm sure many of you are well aware of, to think about health equity within preparedness and response. But for today, I'm going to center some of the examples that I use on occupation as an equity, a health equity factor. So let's just go ahead and get started. I'm going to start by thinking about health equity and at its core being an issue around vulnerability. So for instance, vulnerability to an emerging infectious disease, disaster, or public health emergency is something that impacts anyone who's in that location, right? And this creates a shared vulnerability, right? We all are exposed to an emerging pathogen, for instance. We all have proximity and experience vulnerability to a disaster that's in our community, right? And so in that way, we share this vulnerability, and the discipline of health security and preparedness kind of has this linkage that everyone in a community has a vulnerability to whatever the disaster, public health emergency, emerging infectious disease. And we saw that really a lot with COVID, like we're all in this together, right? That's that sense of solidarity in the sentiment of shared vulnerability, right? But and I'm going to bring in here the scholar Martha Feynman, and she's a legal theorist and a political philosopher. And she does a lot of work around vulnerability, and she defines vulnerability as a universal human condition. So every individual depends on another at some point in time. And vulnerability, she goes on to say, should be understood as arising from our embodiment, which carries with it the capacity for harm, injury, misfortune, whether that's accidental, intentional, or otherwise. So, I'm not saying anything groundbreaking here, and I don't think she is either, in that we are all vulnerable in different varied ways to harm. But a vulnerability analysis looks at the ways that certain people are protected, or that there's privileges that are conferred by the state or broad society through their institutions that make us differentially vulnerable, right? So I may not be as vulnerable as the person next to me because I'm not a healthcare worker. And so I am not caring for a patient on the front lines of an emerging infectious disease. So while the pandemic really revealed a shared vulnerability, it also revealed this disparate vulnerability or differential vulnerabilities that were due in part to a lot of things, but structural inequalities being one of them. And obviously there are practical and structural considerations when we think about protecting people in the case of a public health emergency, a disaster, an emerging infectious disease. So I wanted to kind of give a brass tacks of a vulnerability analysis. So what might that look like, and why is it helpful to us, right? So a vulnerability, if it stems from an individual's location, whether that's a social location, the people you're around, the workplace that you're in, economic, how much access to income do you have, political, do you have protections from the state or the federal government based on your standing in society? All those things make a difference in how much protection we have in a public health emergency. We don't all come in with the same set of protections to these situations. So an example of the ways that institutions and systems advantage some while disadvantaging others is something like immigrants may not be able to access health services in the event of an emerging infectious disease or a disaster. And this could be due to real and perceived barriers around their documentation. They may have fear that seeking help or care or testing in the case of an emerging infectious disease may have implications for their standing at work, or staying where they are in the country, etc. So, and then institutional practices also can give additional protections to people, and that also has a bearing on health outcomes. So, for instance, an ill worker may not always receive sick leave from their employer. So, those are assumptions that sometimes we make that aren't always the case. And this really is relevant, and we call this something different, I think, but it lends itself to thinking about the social determinants of health and thinking about vulnerability as the center, and the social determinants of health as kind of a way of categorizing things. So the social determinants of health are those social factors that cause increased health disparities. So, and we can think about them as the conditions in which people are born, grow, work, live, and age, and those wider set of forces and systems shaping the conditions of their daily life. So when we think about vulnerability, we think about the conditions of daily life where someone may receive protections in the case of a public health emergency or an emerging infectious disease, or may not. So we may be standing on unequal plane here, and some of us may kind of walk in with additional vulnerabilities than others due to the social determinants of health. So the social determinants of health highlight the importance of those upstream factors that are unrelated to healthcare delivery. So we think here about our incomes and our social protections. If I stay home from work, or if I can't get to work, am I going to be able to continue to have income consistency, or am I not? Do I have to go to work to ensure that my family can afford food and the things that we need? Education, which has implications for social mobility and being able to have job stability, unemployment and job insecurity, food insecurity, housing, basic amenities and the environment, early childhood development, social inclusion and non-discrimination. So thinking about the ways in which there are real and perceived limitations and barriers to people being able to access the things they need to be healthy. And then access to affordable health services that are a decent quality. And since we are going to talk about work today, I do want to highlight that a lot of these social determinants of health are very much tied to a person's work. Here in the US, healthcare insurance is often linked to work. Our ability to have income security is linked to our institutional, our work policies around the provision of income consistency, whether or not if we have sick leave, if we have disability leave, those things are tied to work. So I did want to kind of note that even though these upstream factors are not always directly linked to occupation, they often do have linkages to occupation, which will be relevant to kind of some of the things that we talk about today. And social determinants also play a significant role in the development of diseases. We know that they're an important contributor to health and inequalities, and especially with infectious diseases. Findings from previous outbreaks suggest that social determinants of infection risk, right, and disease severity contribute to aggravated inequalities. So we know that when people have a higher risk of contracting a communicable disease, those are going to be impactful for their health outcomes. So occupation as a risk factor for increased risk of infection was made very clear over the COVID-19 pandemic. We had a lot of high-risk occupations that where their work could not be easily carried out from home, and that, they came in close contact with other people. And importantly, preparedness plans often disregard social determinants of health as drivers of disease occurrence and progression. And maybe more importantly, that preparedness planning prior to COVID-19 didn't look at high-risk occupations outside of healthcare work. And so there's a gap there for those in occupations where they continued to be in high-risk setting for contracting disease, but didn't necessarily benefit from preparedness planning that incorporated their health and welfare in robust ways, whether that was thinking about infection prevention and control in those environments, or accounting for access to healthcare if those workers became sick. So taking social determinants into account in preparedness plans hopefully would lead to better planning, though. And so thinking about work being one of those, and thinking about how do we incorporate work and workers into our broad planning moving forward. So how do we kind of account for this? I think that accounting for social determinants of health, there aren't always regulatory provisions that say here's exactly what you have to do, and so there's a little bit of how can ethics help us think about issues like equity in a careful, nuanced way that allows us to kind of dig into the details and plan in ways that may in the future lead to more regulated solutions, but at the very least helps us in our planning be more equitable in regard to preparedness. So here are some of the ethical values that are really central to thinking about preparedness planning and response. So I'll just list them off and then we'll talk about each one in a greater detail. But reciprocity, solidarity, there we have equity, health justice, and health and safety, precautionary principle, harm reduction, transparency, and then the duty to plan and the duty to safeguard, all being really important ethical values that hopefully lend themselves as nice tools to preparedness planning. So first, reciprocity. Reciprocity, I have it on there first because I think a lot of the times when we think about preparedness planning, reciprocity comes into play. Reciprocity requires that society support those who face a disproportionate burden in protecting the public good and take steps to minimize those burdens as much as possible. So when we think about healthcare workers stepping up and providing care on the front lines of an emerging infectious disease or in a disaster setting, those people are owed something in return. They are taking on disproportionate burden, disproportionate risk oftentimes. And so they're owed everything we can do as a community and a society to protect them. We owe them that. We owe them that in return. Health equity and justice. So obviously reciprocity says if you're out there on the front line, we owe you protections in return. Health equity and justice recognizes that there needs to also be fair distribution of health burdens and benefits, that we want to ensure that at the minimum, we hope that we can protect you completely. But if we can't, we're ensuring that we don't exacerbate underlying health inequities. So planning and response that accounts for, right, that we're not always equally vulnerable in these situations. And so how do we account for that in our plans and in our response? The precautionary principle is a guiding principle that really stresses caution. So I think when you think about the precautionary principle, this just means that when we don't know, when we don't understand the transmission dynamics of a disease, or we don't understand the scope of a disaster, that we use caution, and we take maybe more precaution than maybe we normally would because we don't understand the scope of the risk involved. And then harm reduction steps in when we can't take as much precaution as we'd like to, that we have policies and procedures that try to buy down that risk when we know we can't eliminate it, right? And there might be a lot of reasons why we can't eliminate the risk. If you think about early days, in the early days of COVID, when we had to reuse masks, that was a practical choice, right? That we didn't have enough supply, and so we used UV light and different strategies to reuse masks. That's an example of a harm reduction strategy. Precaution would make sure that everyone had the masks that they needed, even if it was unclear, exactly who needed those masks. Precautionary principle would have said to have those for everyone and have the training and things that we need to make sure that everyone could be safe. And harm reduction says, you're not always going to be able to have what you need. There are a lot of reasons for that. How do we buy down risk? How do we buy down harm to ensure people are safe? And then transparency. Transparency is really about being honest about what's expected and what's going to take to get there. But I think transparency always is applied to specific issues, right? And so when you think about something like the precautionary principle or harm reduction, you're using different strategies to keep people safe, right? And you're doing the best that you can in either of those cases, using either of those values. Transparency would require you to acknowledge that, to say, there's a lot we don't know now in the case of taking precaution. And so we want to be honest with you that there's a lot we don't know right now. And so we're using this approach and taking my example of masks, right? We're asking people to mask up for right now. And once we know more, we'll change that policy. But it's being honest and thoughtful about how we communicate with the community about the risk involved due to a public health emergency of any kind. And then the last one I think is maybe the most important. Epidemics, pandemics, public health emergencies are all going to require planning to ensure health and safety of communities. And the U.S. and state governments and facilities have a duty to recognize and plan for foreseeable health challenges. So as I kind of spoke through some of those issues on reciprocity and health equity, really there's a duty to plan and a duty to safeguard for those in peacetime when there's not an emergency, so that we can better account for the issues that people will face, for those vulnerabilities that may be different across our community, so that we can ensure reciprocity. We can ensure health equity to the best extent possible in those scenarios. Okay, so you might be thinking at this point, that all sounds great, but how does this actually work in real life? And so I thought maybe a helpful way to kind of break this down would be to talk through what are some of the ways that healthcare organization can prioritize health equity and preparedness. And again, I'm today using this time to think through the lens of work. There are lots of different ways, as I'm sure so many of you know, to think about health equity and preparedness and response. We're focusing on work today, but there's a lot of different ways to break this down and to think about it as healthcare facilities plan for future preparedness. So I'm going to do this by introducing a case. So I have case one here, and it's the case of environmental service and waste management workers. This comes from a publication, if you want to look at that, that a colleague and I wrote, and I think it kind of maps out for us a way to think about health equity in the space for healthcare organizations. So the case is there is a novel strain of influenza that's airborne transmissible, and it's emerged and is beginning to impact the entire United States. So effective infection control plans really need to include personnel in environmental services and related fields, those who enter, maintain, repair, and clean all areas of the hospital, including patient rooms, and the waste management staff in protocol development, not to be effective. And what we know is to date that this hospital facility has a contract that stipulates that waste management workers will enter the hospital rooms and empty biohazard containers, and that the hospital must provide gloves. So that's what the current contract that those waste management workers are on gives provisions for. And currently, the healthcare organization that we're talking about today is realizing that for airborne transmissible pathogen, gloves are not sufficient PPE, and that N95 respirators would be needed to kind of protect these workers, given what the contract stipulates that they have to go into the rooms. The hospital also has concerns because they don't have enough N95 respirators for waste management workers because there's shortages. And the waste management firm doesn't have an N95 supplier. So they, at this point in time, given the resource demands, they're not going to be able to locate a supplier at this point in time. So the hospital staff is concerned about the safety of those waste management workers who, in addition to not have N95s, don't have training on infection control. So since the contract never stipulated that they would move into those spaces, the the larger kind of team never really accounted for infection control, accounted for them in infection control planning. So how the healthcare facility, the staff involved is wondering, how can the hospital keep all workers safe in this environment, and what factors do they need to consider and as they're working towards trying to keep the health and safety of these workers front and center. And a little bit of background, I think, is important here too, in thinking about safety culture and thinking about risk in these environments. So the U.S. Occupational Safety and Health Administration, or OSHA, identifies hospitals as one of the most hazardous places to work. And healthcare support workers are key in who they identify as at risk, with increasing numbers of fatal occupational injuries occurring between 2017 and 2020, and nursing aides and workers in environmental services and related fields suffering a substantial proportion of injuries and illnesses resulting from healthcare, from the healthcare environment. So we know it's a dangerous place, and we know it impacts the health and well-being of those workers. And the second point is that the inequity in the death and illness among workers is due to interrelated factors. So first being the nature and hazards of the job performed, the risk, right? And then thinking about baseline health conditions of those workers, as well as socioeconomic determinants, and thinking here especially about the social determinants of health that we kind of started this whole conversation with, that those are really important and play key roles in worker health. So we have some gaps in preparedness planning within this case that we're talking about. So the current infection control protocols, cleaning and waste removal, fall to hospital environmental services and waste management staff. But these workers were not invited to participate in planning and weren't offered training to ensure their readiness to respond to an emerging infectious disease, which they're experiencing during this case. And they're also, workers need PPE. And so there's a limitation there for them. That only multiplies by the institution at large that's dealing with PPE and staff shortages. So they may not have the resources, either the physical resources in terms of the supplies, and also the staff shortages. Even if they had the PPE, would they be able to have the staff to train additional workers as they're responding to the event? So also, waste management workers didn't undergo fit testing or PPE training for N95 respirators. So there are additional considerations there. And workers currently are not required to be consulted in the development of an exposure control program. So there's some practical and structural considerations. When we think about the structural considerations, those go back to kind of what the contract stipulates, and then how the institutions may operationalize and plan for who needs to be involved in certain trainings, etc. So the gaps in preparedness planning indicate that even though these workers have a really key role in ensuring containment, I want to point this out, because even though this is a case about a actual facility, it's represented in the academic literature as well. So even though these workers are so key in ensuring containment and operations of key spaces in a hospital or a facility, they're seldom mentioned in the literature on infection control and industrial hygiene guidelines. And I think that this neglect and lack of inclusion of those workers in the guidelines results in less effective infection control practices, which bears out in the actual health outcomes that we experience when a disaster or an emerging infectious disease response efforts are. We're in the midst of response efforts. And I wanted to show this graphic here. This is from a publication. You can kind of see that at the bottom. If it's of interest, you can look at it. Massachusetts did a really good job of having data to look at some of these issues around work, COVID as an occupational illness almost, especially in the early days, where some of us had to go to work and some of us got to stay home and be protected from infection. So what you're seeing here is age-adjusted COVID-19 mortality rates among workers, and that period being March 1st to July 31st of 2020, so very early days, before we had therapeutics, before we had vaccines. And you can see they have on there, they're looking primarily here at workers outside of clinical healthcare workers. And so you can see they have healthcare support, which is some of what we're talking about today, the environmental services and waste management workers. And then they have other workforces and industries that were also kind of manning the front lines: transportation, food, building and grounds, production, contract. They have some kind of the protective services, and you can read on there. But importantly, and for the purposes of our conversation today, that healthcare support being the top in terms of mortality rates among workers. And it makes sense, right? And thinking about how close healthcare support workers are to the disease and exposure, it makes sense that we also see mortality rates being high there as well. And this is an important issue for equity, right? Thinking about that, are we exacerbating that health equity injustice that I talked about a little bit earlier? Are we exacerbating existing inequities and in our health outcomes? Are we ensuring adequate protections to everyone who is putting themselves at risk for the greater community? Okay, so our gaps in preparedness planning. So had workers been considered in the development and execution of infection control protocol, maybe the lack of PPE testing might have been identified earlier, prior to the protocol's implementation, when those deficiencies endangered workers and the community. And I think importantly, thinking here, when we think about protecting workers, we're not just thinking about protecting that worker. We're also thinking about where, especially in the case of infectious diseases, they go home to families, they go home to communities, and we increase the risk of spread, not only at a facility, but within the community if we don't offer appropriate protections to those workers. So hospitals should anticipate risks to the safety of workers within hospitals, including contractors. So ensuring that we're not forgetting about those who may not fall under the employment of the hospital, but thinking about how planning is inclusive to all workers who move through the hospital spaces and who move through the community, and who we may be seeing as patients as well. It's an opportunity to really buy down that risk in prevention as opposed to response. So, health equity in the moment. So say you are responding. This is your situation. You hadn't thought about the contract issues. You hadn't thought about maybe the ways that the contract issues might now be impacting workers who only have gloves. Are there practical solutions? Yes, of course, there are. They're maybe not the best ones, but there are practical solutions. And for this case, the hospital could both conserve N95s and better safeguard waste management workers' health simply by asking healthcare workers, their clinical staff, to pass the waste containers to the waste management workers who are on the outside of the room. So that is an example of maybe what a practical solution in the moment might look like. It's still presents difficulty, especially in when we're thinking about a disease that's airborne, on how much risk is that worker exposed to outside of the room when everyone is in N95 masks that's going in. So thinking about some of that as well might be important. And then importantly, a structural solution might revisit the contract, right? So lack of contractual protections requires institutions to negotiate those structural barriers in a way that impact worker health prior to an infectious disease outbreak. So taking a look at some of those contracts that we negotiate with vendors and ensuring that they really have adequate flexibility given the risk that those workers may be exposed to, knowing that those workers have a vital role to play in response efforts, and ensuring that the facility can adequately account for them. So health equity might look like healthcare administrators considering all workers, including contract workers, in their preparedness plans. Appropriate planning for the hospital, including engaging stakeholders before an emerging infectious disease threat. So as we're doing preparedness plans, really bringing those stakeholders in, bringing the environmental services worker team in, asking them, what considerations need to be incorporated in preparedness plans for infection control, for disaster. What are we missing that might cause increased risk to those staff members as a hospital that is really kind of responsible for that planning? And then being able to look, as you bring those stakeholders in, being able to look at the plans and the contracts and identify ways to maybe renegotiate or rethink things to make those plans more flexible or inclusive of greater protections if the disaster or emerging infectious disease event warrants. And I think, in preparedness planning, we don't always know what's going to happen next. So I think thinking about it in ways where we have plans that can flex to protect the people that will need it most. Okay. So I wanted to shift and speak also to public health. I know that I spoke to healthcare, and I want to make sure that we can kind of speak to public health as well. So I wanted to kind of take the same example of work. We'll talk about work this time. Maybe if I'm invited back, I can talk about other things as well. But I wanted to give really robust, practical examples so that people hopefully can take some of this away and incorporate into their planning. So essential work during an emergent infectious disease. So who else is on the front line? So we just identified maybe a gap in planning for hospitals and healthcare organizations where you have healthcare support staff that maybe, day to day don't need so much effort on PPE training or infection control training, but now we have to think about that differently for a healthcare organization. So how can we think about emerging infectious diseases and work again? Who else is on the front line that maybe we haven't looked at as closely? But COVID certainly gave us a robust example of who else is on the front line. And so essential work, and I'm sure, those of you who were on the front line of the pandemic, that is a familiar term. But essential, I have a list of those included in essential work, those essential workers and their categories. So you can see all essential workers, and this comes from the Economic Policy Institute. They've aggregated all essential workers there, and you can see, not surprisingly, the healthcare industry accounts for 30% of essential workers. But I think importantly, food and agriculture counts for 20% of essential workers. So that's a big workforce that prior to COVID-19 was just mentioned very much in planning documents, but not in a very robust way, not where we were thinking about all the details of what preparedness planning for those industries might look like. So essential worker health. How do we think about essential worker health? Half of essential industries have a median hourly wage that's less than the non-essential workforce median hourly wage. And then we already said that a lot of these essential workers, are taking on the majority of the risk, especially in the early phase. That's the essential work. Really, you think about that as they're still working when we don't have therapeutics, when we don't have vaccines yet, in the case of an emerging infectious disease. So almost a quarter of essential workers are also considered low-income workers. So some of these pieces are hopefully reminding you of our conversation on the social determinants of health. And then low-income individuals have higher rates for COVID-19 of health disparities, and a third of food and agriculture workers don't have paid sick leave. So again, think back of that social determinants of health. We don't all have the same vulnerability to an emerging infectious disease. We don't all have the same protections as well. So important to kind of think through a few of those as we go into this conversation. And I'm going to take the example of meat processing workers. Of course, in Nebraska, this was a really key essential workforce that we ended up thinking about. So, and briefly, meat processing work is among the most hazardous of occupations. Workplace protections and worker empowerment have eroded over time. So again, I want you to think about institutions that confer privileges. Institutions confer protection, right, on people. And so if they don't, we really have an issue where we're not all walking into the same playing field. So the industry has consolidated into fewer politically and economically influential companies. And the industry has also sought to reduce regulatory accountability for the following worker protections. So this is prior to COVID-19. Line speed, which ensures that people don't get hurt because the line's not going too fast, that they can't keep up, and it leads to inadvertent injury. And then reporting of workplace industries. So we really understand, thinking about transparency, we understand how the health of workers is in those environments. And then union involvement. So thinking about advocacy for workers so that workers have agency, union involvement. So their ability to have agency in states like Nebraska has really reduced. Excuse me. So all of those hopefully just paint an introductory picture to the fact that meat processing workers as essential workers really have less protection given to them by their institution, their workplace, as well as the state that allows them to be healthy or have access to the health that they need. And what did that bear out to look like? Well, by July 30th, 2021, 300 meat processing workers had died from COVID-19, and close to 60,000 had contracted the virus. That's 12,000 cases per 100,000 workers. And that's a number that was unmatched in any other workplace over the pandemic. So let's turn back really quickly to our ethical values. We've already discussed them, but how do we think about those things for an industry like meat processing, kind of thinking about the gaps that exist? We haven't thought about infection prevention and control in a meat processing facility. That's a new built environment for us to think about preparedness efforts. And for local public health, and for healthcare coordinators, they're working really hard to respond to hotspots where workers really had increased infection. And there were lots of issues to consider when it came to the response efforts that were needed in the spaces that maybe we hadn't planned for prior to the pandemic. And those planning efforts needed to incorporate on-site protections. So things that happened at the facility, thinking about how do we make sure people have access to masks? How do we ensure that they have good infection control planning for those built environments, especially since there aren't any therapeutics, there aren't any vaccines yet. And meat processing is a very dense populated space, some facilities having up to 5,000 employees walking through those facilities. And then offsite prevention, thinking again to some of our conversation on the social determinants of health, ensuring health equity means that, do they have access to testing facilities? Do they have access to training on infection control? Certainly meat processing workers might never have considered the risk of infection of an airborne infection disease in their facility. And then treatment and remediation, so requires thinking about, do they have access to healthcare? Do they have access to vaccines once available, and treatments once available? So there are practical and structural barriers to thinking about an industry like health, like meat processing workers, right? And it's challenging. So what are those practical barriers? And here are a couple places where myself and some colleagues have worked to outline some of those barriers. And one is the publication you see there. I think some of the practical barriers will always include that there's uncertainty for an emerging infectious disease on the transmission. We don't know what we don't know about an emerging infectious disease. We don't have all the scientific evidence that we would really want. And I think that planning should kind of plan for that, right? We know that there's going to be a lot of uncertainty, as there was for COVID-19, and that there's deficits in research around protecting essential industry workers in different environments. We know there was resource scarcity in PPE. And then we know that local public health departments and healthcare coordinators are very spread thin. And so how do we think about supporting those who are going to have to respond? We think about that duty to plan, duty to safeguard, to not only tracking disease spread in their environment, but prioritizing those who are really at greater risk for contracting the infection and for bringing it back into the community from their occupation in some cases. And then we know that there were structural issues as well. And I want to highlight these, even if a lot of us don't have any control over this. I think they're really important to mention. For COVID-19, we had an executive order that kept industries open, that it allowed industries to stay open. But we also had less protective PPE recommended by the CDC for those industries. And that goes back to our practical barrier, right? Some of those facilities, an N95, giving an N95s to meat processing workers would require training on N95. It required fit testing for N95. It required a respiratory protection program. So these two things, the structural and practical barriers, are very much intertwined. But I think an important piece for keeping industries accountable that get to stay open is that there needs to be regulatory accountability for these industries. If they get to stay open, they have to ensure protection of those that are working there. So OSHA did not issue an emergency temporary standard for infectious diseases for those outside of healthcare. And so I think part of thinking about that being a really key barrier to the health and safety of those that were working on the front line of the response. And then the CARES Act, which was a really important piece of legislation that came through to protect so many and give access to so many essential workers to have access to healthcare, did not include undocumented workers in its provisions. So what solutions exist, right? There are a lot of things to kind of account for. There were a lot of things that happened, and the scale of the pandemic, I think, made it so difficult for so many of us to respond. But what are the practical solutions and the structural solutions that we should be leaning towards in our preparedness and our preparedness planning? So some of the structural solutions that I've kind of alluded to are the ability to issue enforceable regulations to all essential industries to keep workers safe. So thinking back to reciprocity, thinking back to health equity, having enforceable regulations keeps people accountable for the safety of those who continue to go to work and take on additional risk so that our communities can stay operational and so that we can continue on even in the midst of an emerging infectious disease or a disaster. And then pandemic policy needs to extend to vulnerable, undocumented populations too. So again, thinking about the structural issues that, there needs to be exceptions or mechanisms for exceptions so that anyone who's going to work and taking on that risk can receive care if they become ill, and that shouldn't be a barrier. And then I think allowing for organization, and this Essential Bill of Rights, thinking about how workers can organize to ensure that they are protected. How can they come together in ways that contract workers, gig workers, those who may not have the opportunity to unionize but have similar work environments to those of meat processing, can have agency to advocate for the health and safety of workers and of their communities that they live in. So practical solutions. So critical infrastructure industries need to have safe workplaces, but I think, thinking about infection control strategies to go in those built environments is a continued need. And then state and local health authorities really thinking about preparedness planning efforts to support those workers in their planning. How do we prioritize them? How do we prioritize them in infection control efforts? So thinking about the hierarchy of controls and what administrative and engineering and PPE mitigation strategies are available to us as those who are situated either in public health or maybe also for healthcare coordinators as well, thinking about the populations that they serve. And I think, really being able to think about this in preparedness as occupation does really have important implications for disease risk and the risk that those that will continue to go to work have. So future work, what are the optimal, thinking again about what are the optimal infection control strategies for essential workers and workplaces, and how can essential worker communities better define those research agendas? So hopefully those two, the two cases that I gave you show you this at different levels. But I think if you're to take anything away, thinking about how do we bring stakeholders from these communities into our planning so that they can help us, whether we're at a healthcare facility, whether we're a healthcare coordinator, whether we're in public health. And I know so many of the people that I've worked with are doing this, but can help bring those voices in so that we understand the risk of those who may be on the front lines of a disaster, a public health emergency, or an emerging infectious disease, allowing them to help us plan and define research agendas, exercise agendas, and preparedness plans moving forward as we think about health equity and the implications for that for preparedness and response. So I will go ahead. I think we have a few minutes for a conversation, and I will go ahead and turn it over to Lauren.
Yeah, thanks, Abby. Great presentation today. We did have a question here in the chat. So they appreciated the examples of hospital efforts, but what suggestions would you have for a healthcare coalition and incorporating equity into their preparedness and response plans?
Yeah, that's a great question. I think one of them, if we're going to take the examples of work, since that's what I kind of centered on today, there's a lot of different ways to think about this. But I think it is identifying maybe broader stakeholder groups that should be included. And I know I've done some work with public health, but I think thinking together, the intersection was so clear on public health and healthcare. And we know for social determinants of health that we see at the bedside inequities, but those happen upstream. So how do we have broader conversations about risk factors, or, if you're in a local community, thinking about crisis standards of care planning, what things do we need to be thinking about for response that we can think about now? We have the time to think about this now, and have conversations, organizing conversations with broader stakeholder groups. And that's going to look different for different localities, right? For those of you who, the meat processing example was something that you lived day in and day out. How are you, to what extent can you, and how are you able to reach those stakeholders? For those of you that may work closely with Indian Health, how are you able to incorporate those stakeholders into your planning so that you understand and you making those connections? We don't always know what the event will be. We don't know what a disaster or disease may bring, but how do we begin planning to account for the social determinants of health that those communities may be facing?
Yeah, thanks, Abby. I think you bring up a lot of good points, and planning always comes before response. So I think figuring out how to incorporate that into our planning. Well, I don't see any other questions here, so I appreciate your time today presenting to us, and I appreciate everyone that participated. I'll go ahead and put the CE information in the chat, and the webinar will be recorded and then placed on our website within about 3 to 5 business days. So with that, a happy almost weekend, and I hope everyone has a great day. Thank you.
Thanks, Lauren.